Everybody, Ted Gottlieb for the Senior Learning Institute. Thanks for watching this short video. Today, I'm really excited that we have Joshua Bennett with us. Josh is with Accent Care Hospice and Palliative Care of Missouri. He's going to educate us on the basics of hospice. And then obviously, if you have any more questions, we'll let you know how to get a hold of Joshua. So Joshua, thanks for being here. Appreciate it.
Thank you very much for having me, Ted. It's an honor.
Oh, appreciate it. So, hey, hospice is really confusing and it took me forever to figure it out, and I still don't know that I have it right. So maybe you can kind of dumb it down for me a little bit, and in less than a minute, because that's about my attention span. What's hospice and where is it provided? What do I need to know? What's the basics?
So the basis of hospice are that it's a service that's an entitlement, just like Social Security or anything else that we all deserve and have a right to have access to at the end of life. And Medicare and the government define end of life parameters as in the final 6 months. So once someone is, by a physician's best estimate, within 6 months of passing away or have a 6-month prognosis, they would qualify for hospice. And hospice care can be provided anywhere that individual calls home, whether it's their private residence, an assisted living, a nursing home. Maybe they want to switch places and go live with a relative, but it's wherever they want to call home. And we come in and provide the extra layer of support. And it's not just focused on the medical needs of the individual, but psychosocial, spiritual, and everything around that.
Got it. I've seen hospice at different levels. I've seen hospice with older adults who you can kind of feel and tell that they were towards the end. But I've also seen people that were younger that have had hospice care that have graduated from it, which always confused me. So you said a 6-month prognosis. So if I don't die within 6 months, am I done?
No, not necessarily. So to your point, people who need hospice are all different ages, have all different medical histories, backgrounds, and needs. So we don't take a blanket approach to anybody's hospice care. So the first thing we do is we create a plan of care for that individual. And to continue to qualify for hospice, occasionally the individual will have to be recertified by 2 physicians as still being hospice appropriate, meaning on that day, they still have a prognosis of less than 6 months. However, there are some rare cases where patients actually show marked improvement when being on hospice through the support of the hospice team, med reconciliation, doing lots of different therapies, and that total care human approach, where some patients who once qualified and needed hospice care for 3 or 6 months no longer qualify for it. And so they would be discharged or graduate off hospice services. However, we would continue to follow that individual to make sure that all of their needs were being met. But we've also had patients who've been on services for over a year continuously, because every time they be recertified, again, that prognosis is based off of that disease runs its natural course, or the trajectory of that person's healthcare runs its natural course. So people can outlive that. It's based off the best judgment of the physicians who are certifying for eligibility.
Okay, so I could get better, come off hospice, and then maybe go back on, or hopefully not. But I guess one of the things I understand is that if I or a loved one is receiving hospice care, then I'm not receiving any medical care or curative treatments. Help me understand how that works.
Yeah, so in order for someone to qualify for hospice, besides the prognosis of 6 months, one thing that we really look at is a transition over to what we call comfort care, meaning that in most cases, that individual will no longer be pursuing curative treatments. Oftentimes, people who elect hospice or people who resist electing hospice think that it's them giving up, that they have to stop all treatments and medication. It's very important that your listeners understand that electing hospice care and the help of the hospice team is not giving up, and they're still going to be treated. We still treat symptoms. We treat things like pain and nausea and shortness of breath, but we may not be pursuing curative treatments. For instance, if a cancer patient was receiving chemo and that chemo's no longer being beneficial, or it's effectively treating that cancer, that person may elect hospice. And at that time, they would no longer be able to have their insurance continue to pay for that chemotherapy. However, there are some instances when, especially patients who have a lot of chronic conditions happening at once and overlap, where individuals will be able to utilize the hospice benefit while also pursuing some curative treatments for other diagnoses. So it's very much a diagnosis-driven specialist and a benefit that everyone can tap into. But I always tell people, if you're unsure, reach out to your local hospice and have a conversation, because you might be surprised with what you're still able to do and accomplish, in hopes of maybe something happens and you do get better and you no longer need hospice.
Yeah, it seems like that's the best thing to do, is to make the phone call and ask the question, because, like many things, we don't know what we don't know. And I sometimes use the example of my dad. Um, by the time we figured out that hospice was what he needed, it was really already too late. Where had I been better informed, I think by the people that were treating him, as well as I had better information or knowledge, kind of like what we're doing here today, I might have suggested that we started hospice much earlier, and he would have had I guess, a quieter and maybe even more peaceful death. So making that phone call is really important. You had mentioned something about comfort care, but then there's also this term palliative care. Is that the same thing?
So it can be. So let's define palliative care real quick. So palliative care is emphasis and a discipline of medicine focused on alleviating symptoms and providing comfort for individuals, but maybe not necessarily at end of life. So you may have an elderly patient who is 75 years old, who struggles with, chronic pain and has COPD and CHF, but they're nowhere near fitting that 6-month prognosis, and needing hospice or even qualifying for hospice is years down the road. However, they're still suffering and have issues that need to be addressed now. So palliative care is really a multidisciplinary approach focused on alleviating symptoms of discomfort and also working on better processes for chronic disease management. Now, that may sound very similar to a lot of what hospice accomplishes, and that's because hospice is also palliative in nature. So we always say, all hospice is palliative care, but not all palliative care is hospice, meaning it has a similar part of the discipline, but it's much more focused around interactions with some supportive care like a social worker, and then a provider, a physician, nurse practitioner, PA, really focused on comfort around medicine reconciliation, disease management, and disease education, where hospice includes that, but then so much more.
Right. So you answered the question I was going to ask, is who actually provides that palliative care and who kind of puts all this together? Because, there's so many moving pieces to this particular topic that it's hard to figure out where things go and who puts it together, and whether I'm getting all the services that I need. And you had mentioned, I believe you mentioned a social worker or a care manager, but somebody, an advocate who knows what they're doing, who can put all these pieces together. Because boy, especially if you're talking with someone who's senior and elderly, and you've got, let's say, one spouse trying to help another spouse and not knowing what questions to answer, it's really crazy. So having someone there to advocate for you is great. So I mean, if someone needs that kind of help and they don't have the resources, I mean, where do they turn?
So just like with hospice, I say reach out and give us a call. I think at the end of the day, even if we aren't in a position to help an individual, we take a lot of pride in the fact that we may know someone who can. So a big part of palliative care and hospice care is just helping people understand what's going on, what's really happening with them, with maybe their disease, multiple diseases or chronic conditions that they may carry. And so there's a lot of education and understanding that gets built along with that. And we know that with that type of one-on-one approach, we also help build trust. The healthcare system is a beautiful thing. We know so much more about the human body and how to provide care for individuals than we knew even 10 years ago. However, what we find being the number one issue, a lot of people struggle with not knowing what they know. And you mentioned maybe you would have elected the help of hospice sooner for your father. It really comes down to having a full understanding of what's going on with that individual and what's happening with their body and their diseases. So we spend a lot of time around education and disease trajectory, disease, living with the disease, and how we manage it and manage these chronic conditions so that it alleviates the most pain, most stress, most distress, while also providing some sense of comfort and control for those individuals.
Got it. You had said earlier that the hospice care was free. So let's follow up on that in regard to how is it free? Who's paying for it? And is this education part of it free as well? So if I don't engage you as my hospice provider, is all the information that you're going to give me also free as well?
Yeah, so in regards to hospice, hospice is covered for your Medicare patients at 100%. So meaning that any medication, any care, nursing visits, social work visits, chaplain visits, any medical equipment needed for that individual's care for their terminal diagnosis is covered at 100%. Now, someone who may have multiple diagnoses and things going on with them and may still want to receive some medication for something unrelated to their terminal diagnosis Medicare would still cover that at the typical 80% range, but anything related to that person's hospice care underneath that diagnosis is covered at 100%. And that includes anything that takes us to properly care for that individual. We, for some people, fortunately, get on hospice right when they meet that criteria. And maybe we don't need to spend as much time supporting them and working on those things because they haven't gotten so bad that we have to see them daily. But as the individual's needs change and we have to change our plan of care, nothing changes for that individual in regards to coverage from Medicare. There are no additional costs. Palliative care, as I said before, is provider driven. It's about a one-on-one relationship with a nurse practitioner or a physician. It's billed just like a doctor's visit and covered the same way any individual's doctor's visits would be covered by their insurance.
Right. So I guess two questions. The first one is, when it comes to hospice care, is the hospice care giver or provider there all the time? I think you hinted that as things progress, you're there more frequently, but let's just say we're in the early stages and we're getting started. How many times a day, a week can I expect to see someone from hospice? And if that's a short period of time, then who is the balance of the care for that particular individual falling upon?
Great question. So to your point, right, hospice isn't there 24/7. So our goal is to support individuals and also support their family, their loved one, and their care team with, again, education around what things look like, how to best support them, how to reach out to us if they need us. But we're there to provide the intermittent care and to guide the plan of care for that individual and to empower that individual and their loved ones and their care team to help take care of them where they call home or where they want to be in accordance with their wishes. So as I mentioned before, this is really about that control factor of having someone in your corner to help guide things and help prepare you for that. Now, if as an individual needs more care, we will be there more frequently, but the only time the hospice team would be caring for someone 24/7 around the clock is if they have an unmet need. They have pain that's out of control that we can't do with intermittent visiting or with different control methods, where then all of a sudden we would do continuous care or general inpatient care to provide an extra level of care for that individual. And then one thing that I'm really happy to say is that with hospice involved, there can still be other members of healthcare or supportive care services involved for that individual. And typically when we're providing care for someone on hospice, but they also have the support of a care team, like someone who does at-home care services or a chore worker, those individuals always do better because they have that additional layer of support there around the clock to help them as well.
Right, that little bit of respite, if you want to call it that. So I know oftentimes, it falls upon a family member, or if there is no other family member, a friend, or sometimes we bring in an in-home care company who can provide those companion services and those type of things. And then maybe you might need some skilled help as well. So, but then again, Medicare takes care of that. So it really takes a team of individuals. And I love the fact that that the hospice team can help put some of that together, maybe in coordination with the care manager. So I think that's awesome. You touched upon something that I caught, and I meant to ask you earlier, but where we receive hospice, that can be anywhere, correct? At home, in a living community, anywhere.
Yeah, and that can change while you're on hospice. So say an individual is at home at their private residence, and their main caregiver is their spouse, but the spouse is kind of having some caregiver burnout and they need a break. Hospice will pay what they call respite stay at a facility, at a skilled nursing facility, where they will help place that individual. The hospice team will still go there daily to provide care for them, but just to give the caregiver a break as well. And then say that person decides to permanently move into a long-term care community, we will follow them there. And we've had the opposite happen. We've had where someone's in a long-term care community following multiple hospitalizations and they're no longer meeting goals of rehab and it's time for hospice, and we admit them onto hospice in a facility. But after working with that individual and their loved ones, they say, you know what, we really want to bring dad home. Right? We want him, this is where he wants to be, we want to bring him home. We will help make that happen. We will provide that care wherever that individual is located. Typically, the only exception to that is if an individual, while on hospice care, decides that there's something going on and they want to go to the hospital, we would then have to discharge that individual from our services so they could be admitted to the hospital. But if they elect to come back onto our services following discharge from the hospital, we will do that.
Great. One last question for me, and then I'm going to ask you to add whatever we haven't discussed and also summarize if you don't mind.
Sure.
The tough question is, but I got to ask it. What happens when the person passes away? What does your role then become? What additional services are available? What do I do after that happens?
So when we receive the call, if we're not there already, that one of the patients we've been honored to care for passes away, we instantly dispatch one of our nurses or clinicians out to the home to provide end of life care, to help bathe the individual, get them prepared for transport to the funeral home or wherever it is that they're going to be, and also start immediately providing support to individuals. And it's very important that when I say start providing support, I mean posthumous support, support for the individual, for that family after their loved one has passed away. But we're already providing that support days, weeks, and even months ahead of time. Family members of people who are on hospice often experience what's known as anticipatory grief, meaning they're anticipating the death of their loved ones. So they're already grieving, even though their loved one hasn't passed. So we're constantly identifying those things, offering emotional, spiritual, social support to those individuals as well. And then our care team, including our social worker, rally around that family to make sure that all their needs are taken care of, that they're not alone and it's not just on their shoulders and we're no longer involved in their care. And then following that, our bereavement specialists and care coordinators continue to follow those loved ones and family members for over a year, providing additional support and resources where we work on things like support groups, providing them counseling as needed, getting them in touch with additional resources as needed, but also working on things like legacy projects and helping them find ways to heal that's in line with their own personal preferences, whether those be spiritual, cultural, or just family specific.
Wow, what a wonderful service. You mentioned Medicare covers this, but what if the person's not Medicare eligible at that point? Then what?
So we will always verify their insurance. If they have a private insurance for someone who's less than 65, we always verify insurances, but almost all insurances cover the hospice benefit and have it looped in. And for those individuals who have a Medicare replacement plan, currently those plans don't cover the hospice benefit. But if you have someone who has a UHC Medicare replacement plan, what happens is their hospice care gets brought back under traditional Medicare and reverts back to that. So almost every major healthcare plan has some form of hospice. Some private plans may only cover 90% or a certain percentage. So it's really important to verify, and that everything looks at things like what's in network and out of network, what their deductible looks like, if that's been met or not. But typically, if we're bringing someone onto care without Medicare insurance and it's not covered 100%, it's usually following multiple catastrophic events and hospitalizations. So deductibles are usually met at that time.
Wow, what a wonderful service. How did this ever come to be? How does it, hospice I understand, but how is it that we've been able to take advantage of this benefit? Whose idea was it in the first place?
So providing care for the sick and dying is something that is innate in human nature that we've been doing all along. But the heart of hospice comes from the heart of volunteerism. There have been a lot of different programs over the years that were all volunteer based about providing care for sick and dying and the scared at the end of life. And Medicare recognized that spirit of volunteerism as the right thing to do. And they came out with the hospice benefit around 40 years ago. And a key part of the hospice benefit also is a mandate that 5% or greater of our patient care and our time providing this crucial service in our community has to be made up by volunteers. That's part of the Medicare conditions of participation. So it all comes from a beautiful place of volunteering and helping those who need our help the most.
That's awesome. Thank you for that. I was curious. All right. So sum it up for us, if you don't mind. For someone who's just tuning in at the very tail end, why don't you just do a quick summary for us?
So hospice care is a beautiful thing. Often people are worried about it. They don't know what they don't know, and they just get concerned about the fact that their loved one may or may not be dying. I always tell people, if you're unsure, please give us a call. We never pressure anyone into any services that they don't want. We just want to help empower people with a greater understanding of what's going on and what their options are. And if you feel that you or a loved one have a prognosis of 6 months or less, if their disease ran its natural course and that you need help, please reach out to help. Every hospice in St. Louis and every hospice across the country all have the same mission, vision, and values of helping support patients and families at end of life. And we honestly are here to make sure that no one is alone, no one feels alone, and that everyone has the support that they deserve to pass away and die with dignity and grace.
That's wonderful. I appreciate that. You've really summed it up, and it just reminds me of the fact that we really need to be our own advocates, or have an advocate for us who can really help put all these plans together. And that's what we're trying to help do here at the Senior Learning Institute. Joshua Bennett at Accent Care Hospice and Palliative Care of St. Louis. Appreciate you being here. Thanks again. And if someone wants to get a hold of you, how do they best do that?
Again, thank you very much for the opportunity, Ted. So if someone would like to get more information, I suggest that they just give us a call at our office, 314-909-6200. Anyone here is able and willing to speak to anyone who just has questions, who wants to learn more about the benefit and have a greater understanding of the options that are made available to them.
Great. And also, if you want a convenient link to Accent Care's website, you can go to the Senior Learning Institute website under resources, or just in case they want to skip that step, Josh, what's their website address?
www.accentcare.com. That's ACCENTCARE, Accent Care, all one word.
Great. Now that's you're national, are you not, in scope?
Yeah. So we're a national company. And if they want specific information, if they just go under services, they'll find hospice and palliative care services, and they can review all the information there. We have a very informative patient and family information hub with videos and feedback and other opportunities to engage and learn more about this beautiful benefit.
Wonderful. All right. Well, thank you very much, Joshua. Appreciate it greatly. And I want to thank you all for watching this video. And by all means, if you want any additional information on just about anything senior, please go to the seniorlearninginstitute.com website. All sorts of resources there for you. And you can always reach out to me and I can connect you to whatever resources you need, both here in the St. Louis metropolitan area or really anywhere throughout the country. Thank you very much for watching.